A very big hello to all my dear students. Welcome to your favorite channel, You and I with Dr. Ruchi Rai. Yes, so we are going to continue with our rapid fire FMG revision. So the next slide is this one. Okay, it's a continuity of our previous session. So I started with the next slide here. So looking at the slide, we all know we are talking about the layers of the retina. It should be absolutely very, very clear to you all when we talk about retinal layers and what is asked. Okay, so I'm making things simple for you. It's already written here, but okay, let us draw it. It becomes more easy. This is the outermost retinal pigment epithelium. Then there is a gap. This is subretinal space, right? If you just learn in my style to make it simplified way. Then comes, of course, the layers of rods and cones. And then comes the external limiting membrane. Then it is outer nuclear layer, outer plexiform, inner nuclear layer, inner plexiform, right? Then you learn as ganglion cell layer. You can see it here. We are making this only. We have just made it through one line. Then the ganglion axons of all the ganglion cell will form the nerve fiber layer, and then comes your internal limiting membrane of the vitreous, right? This is called posterior hyaloid membrane, and this one is your anterior hyaloid membrane. This is the vitreous. This is the anterior segment of the lens of the eye, and this is the lens, right? This is the lens, right? So this much is clear to you all. Okay, so once this is clear, we next talk about, I hope you should be knowing this, what is retinal detachment, separation of the outermost layer from the rest of the layers. What are these rest of layers known as? Neurosensory retina. So it is the separation of neurosensory retina from the retinal pigment epithelium. इसी को बुलाते हैं retinal detachment, right? Okay, ये subretinal space के along separation होती है. Why it is so? Because it is weak embryologically. That is why it separates from here. Okay, what is the next thing you should know? That the blood vessels are at two levels. One is between OP and IN layer where they are vertical and perpendicular, and another is along nerve fiber layer. This is the reason any hemorrhage here looks like a dot and blot. Any hemorrhage here looks like flame-shaped hemorrhage, right? So these are the basic things that we should be absolutely very, very clear. What next they can ask you? Of course, you know outer nuclear layer means nucleus of rods and cones. What does inner nuclear layer contain? So inner nuclear layer has bipolar cells, amacrine cells, and horizontal cells. Just remember these. And what is Muller? Muller is spanning the whole neurosensory retina, and it is a supporting cell, that is a glial cell. Okay, so basics of the retina should be absolutely very, very clear. Okay, so this is also asked, what is there in an inner nuclear layer? So these are the cells, bipolar, horizontal, and amacrine. Do you all know what is outer blood retinal barrier and inner? Outer means strong adhesions of retinal pigment epithelium. What is outside this? This is your choroid, and of course the inner layer of the choroid. Between the two, this is what is called Bruch's membrane, right? I think now it is absolutely clear to you all. So whenever I start a retina discussion, I always start with anatomy. It's very important. So these strong adhesions of RP, this forms the outer blood retinal barrier. So I'll speak more here because this is a rapid fire revision. So when you say outer blood retinal barrier, what we have to understand that it is when this will be broken, there will be leakage of the fluid from the choroid into the subretinal space causing shallow RD, and this is what is called CSR. So just remember outer barrier is broken in CSR. What is the inner barrier? Inner barrier nothing but integrity of the blood vessels. This is your inner blood retinal barrier. Means when ye broken hoga, inner blood retinal barrier, when this is broken, means there is increased capillary permeability and leakage. Okay, so CME will occur due to breaking of inner barrier. CSR is occurring due to breaking of outer barrier. Clear? Next slide. Okay, so you can see what is retinal detachment we have discussed. Most common retinal detachment exam question. This is of course regmatogenous. Where is the regma? Regma ये है, regma का मतलब होता है break. So the break can either be a tear, as you can see in this, it is a horseshoe shaped tear, or it could be a hole, right? So most common retinal detachment, it is always regmatogenous retinal detachment. Just remember this much. It is regmatogenous retinal detachment. Okay? Okay, and how does the patient present? This is important, as if a curtain is falling in front of the eye, right? Okay. Another question on regmatogenous is Schaffer's sign. What is Schaffer's sign? It is dispersion of pigments in the vitreous. We also call it the dispersion of pigments in the vitreous due to retinal break. Remember that, and it is also called tobacco test. Next slide. What is this type of RD? This is your exudative. We can see a convex configuration. Exudative matlab, if you have you already know the diagram. Any pathology in the choroid, when it percolates in the subretinal space, it can lead to RD. This is exudative. What is exam question? Is shifting fluid. Shifting fluid is a feature of exudative, right? Shifting fluid is happening due to change of the posture. Next type is your tractional. So we know, if you go back to the basic pathogenesis of any vascular disease of the retina, it starts with hypoxia, increased capillary permeability, leakage, more hypoxia, release of chemotactic factors, neovascularization, right? Okay? Should I repeat? It is hypoxia, increased capillary permeability, more hypoxia, then release of chemotactic factors, neovascularization. Now this neovascularization, if you look here in this diagram, these are the tuft of vessels. So when these vessels, of course, are always accompanied with fibrous tissue, and when they contract, it pulls the retina, and this is the reason of one of the blinding complications, that is tractional retinal detachment. This is what you are looking here. These are the traction bands, and we are talking about tractional retinal detachment. Okay? Okay. So you should know what are the three types of RD, which is the most common. Where do you get shifting fluid? Where do you get Schaffer's sign? How will a rhegmatogenous eye, how does it present as a curtain falling in front of the eye? These are some important questions. Of course, the basic what is RD should be very, very clear to you. Is it okay? I'm sorry, I have to be a little faster here. Okay. What is the slide? If I ask you, give me the diagnosis of this whole slide, all the pictures together. This is CSR. How do you know that? Can you see this is the ring reflex on the right? So this is your central serous retinopathy. First exam question, it is mainly seen in young males. And if it is an acute type and not chronic type, then it is self-limiting. So majority of the patients, the disease is self-limiting. This is also acute. Okay, so remember these two cues. One, it is mainly in young males and it is self-limiting. If it is chronic, then of course it can lead to RP damage and other complications. Okay? Another exam question, steroids aggravate CSR. So steroids are contraindicated. Okay? What do you see in this picture? So you're clear with the ring reflex, right? Okay. What do you see in this picture? This is your OCT slide, which is showing the foveal detachment. This is your CSR, because it is mainly the shallow retinal detachment only at the fovea. And I can also see that retinal pigment epithelium is also being disturbed here. That means it could be a case of chronic CSR. We do not know, of course. Then we talk about the third, of course. What is this? I hope you remember which investigation is this one. This is Amsler grid, and what you are seeing in the Amsler grid, यहाँ क्या दिख रहा है? टेढ़ा मेढ़ा दिखना. The patient is seeing distorted image. This is what is called metamorphopsia. Okay, so ये हमें क्या दिख रहा है? Metamorphopsia. Okay, we come to the next slide. What you see is a fluorescein angiographic picture. I can see even the circle of the ring reflex. I can see leakage, which is ink blot pattern. Okay, so ink blot is a feature of CSR. What is the other pattern in CSR? Don't forget smokestack. Smokestack, how does that look like? By chance, I missed this picture. It is something like this. Just have a look. What is smokestack? Okay. So mushroom shaped manner में leakage जो होता है, this is called smokestack. That is also a feature of CSR. These are important exam questions. Okay. Then we talk about what is this. This is again an fluorescein angiography. What do you see? The leakage that I see, fundus fluorescein angiography picture. Leakage is flower petal pattern, and flower petal pattern, as you can see, everything is radial like this, right? And this flower petal pattern is a feature of, you answer CME. So that is another exam question, right? Okay, we come to the next one. What do you see here? So this is the slide with multiple flame-shaped hemorrhage, which we can see here. These are the flame-shaped hemorrhage, right, all of you? And what is this? These are the cotton wool spots, right? So this is a splash sauce appearance of, कहाँ मिलता है? Splash sauce appearance of CRVU, ठीक है? So this should be clear. Another question on CRVU apart from this, बताओ. Another question is about 100-day glaucoma. Chalo, let's understand this as well. We go back to our diagram. One blinding complication you understood was tractional retinal detachment. Isn't it? What is the other complication? The whole hemorrhage can fill the vitreous, and another blinding complication can be vitreous hemorrhage, right? So these are the two we have discussed. And what is the third? Any hypoxia which involves the anterior segment can lead to neovascularization of iris, rubeosis iridis, और इससे क्या हो जाएगा? Neovascular glaucoma, isn't it? This is the third blinding complication. Clear? So what is happening in CRVO? This neovascular glaucoma is seen after 100 days. This is the reason इसको हम बुलाते हैं 100-day glaucoma. It's a feature of CRVO. Next slide. What do you see? I can see a cherry red spot. Yes, we are looking at cherry red spot. Very, very important for your exams. Repeatedly asked. Cherry red spot, what can be the causes? Of course, you know when the central retinal artery occlusion. What are the cause of artery occlusion? Generally embolism. You should know that embolism mainly, what is Holland-Hotz plaques? Holland-Hotz plaques are nothing but cholesterol emboli. Right? This can be asked. This has been your question. This is cholesterol emboli. What can be the second cause of CRVO? You will learn it as, it can be mucormycosis. CRVO can also happen due to mucormycosis. Uske baad, what next you have to know? The second cause of cherry red spot, we all know, is Berlin's edema. What is the other name of Berlin's edema? Due to blunt trauma, we call it commotio retini. And what is the third cause? Is, just learn like this, depositions. So all the sphingolipidosis and gangliosidosis. I think we have learned this so many times. Tay-Sachs, Niemann-Pick, Gauchers. Of course, we do get cherry red spot. It is debatable, so I am stressing on this. We do get cherry red spot in Gauchers, then GM1 gangliosidosis type 2, right? So remember all these causes. Even Sandoz disease, sialosis, सब में मिलता है. Chalo, next we talk about what is this slide. This slide is nothing but if the patient has lucky enough to have a dual blood supply, when his central retinal artery is occluded, still he is getting some supply at the very center of the macula and a very small field is left. This artery is, exam question, cilio-retinal artery, which is a branch of, exam question, you will answer short posterior ciliary artery. Okay, and which leads to, again exam question, you will answer tunnel vision or tubular vision. Okay, just remember this. Okay, when you talk about tunnel or tubular, don't forget two drugs which can lead to tunnel or tubular are vigabatrin and quinine. Okay, we talk about next one. What is this slide? Of course, this is, we are talking about, if you look here, this is your, what can you see here? You should be able to recognize these are the hard exudates, right? So these are hard exudates, and this is what is dot and blot hemorrhage, right? So we are talking about few hemorrhages and exudates. This is a case of background diabetic retinopathy. Okay? And then when you're doing a fluorescein angiography, what is the first sign of DR? Exam question. First sign you will answer is microaneurysms. Right? So what you see here is microaneurysms. Then we come to more hypoxia, more damage, and when there is more hypoxia, we lead to more cotton wool spots due to more damage. This is what is, can you see? A lot of cotton wool spots, flame-shaped hemorrhage, large blot hemorrhage. Right? So this is what? Pre-proliferate. And of course, in this one, in the peripheral retina, you can even see the looping and beading. We can appreciate looping here, looping of the vessels. So what is this? This is a pre-proliferative diabetic retinopathy. Right? And when there is a neovascularization, how do we know this is, see here, this is what is NVD. We can see the neovascularization at disc. These are large blot hemorrhages which are called cotton wool spots are nothing but, sorry, not large blot hemorrhage. Let me correct myself. Cotton wool spots, they are what? They are soft exudates. Then of course, this is a large blot hemorrhage here. This is, what is this? This is your flame-shaped hemorrhage. These are hard exudates. So, and we can even see a neovascularization at the disc. So, we are looking at proliferative diabetic retinopathy. We will not forget this, okay? So, this is a proliferative diabetic retinopathy. And of course, when you talk about, please revise your ETDRS classification of diabetic retinopathy, okay? So, do this homework. ETDRS classification ko revise kar lena. And of course, the first line of treatment for if it is a PDR, we go for pan-retinal photocoagulation. But if it is non-proliferative, we first go for intravitreal anti-VEGF injections. Don't forget that. Okay, they have other questions in the diabetic retinopathy like For example, which is the most important factor? Please remember, it is duration of the diabetes is most important factor, and glycemic control becomes the second most important factor is glycemic control. Okay, that is second most important factor. Okay, can we remember this? And we come to the next point. Next you have to know is about when should you first examine the fundus. This is also asked. So if the patient is a type 1 diabetes, we wait for 5 years. So after 5 years. And in case of type 2, immediately. If type 2, we have to do it immediately. Right? So these are the important points regarding DR that we have to remember. Why immediately? Because we just don't know since when the patient is diabetic. Okay, what is this slide? Can you give me one diagnosis for all the pictures here? So what we can see here, look at this. Look at this one. This is your annular crescent, right? This is the tigroid fundus where the choroidal blood vessels are more prominent. The white lines, what are these? They are lacquer cracks. This is break in the Brooks membrane, right? Yes, what do you see here? It is chorioretinal atrophy, patches, right? What do you see here? I can't see the disc. I'm looking at the periphery of the retina. What I see is the lattice degeneration. Yes, so we are talking about what? And of course, what do you see here? This is the ultrasound B scan. B scan showing you posterior staphyloma. Okay, so what are you looking at? The diagnosis becomes pathological myopia. Simple. So this is a case of pathological. What is pathological myopia? Pata hai na? Any myopia with fundus changes due to excessive elongation of the axial length of the eyeball. Okay. Yeah. We come to the next slide. What is this? Of course, this is your alternate areas of hyper and hypopigmentation. We are talking about bullseye maculopathy. So at your level, just remember two main causes, chloroquine and hydroxychloroquine. Both can cause bullseye maculopathy. Right? One more is cone dystrophy if you want to know more. Okay, then we talk about what are you looking now? Very, very important. This is what is leukocoria. What is leukocoria is white eye reflex, isn't it? So leukocoria, which is white eye reflex. And of course, most common cause of leukocoria is congenital cataract. But yes, please remember and revise the causes of leukocoria. That could be due to central choroiditis, which is due to toxocariasis, or central colobomas, or endophthalmitis, or central retinal detachments, PHPV, Coats disease, right? So all these DDs of leukocoria, ek bar revise kar lijiyega. Secondly, of course, the main cause here is retinoblastoma, right? Okay, so when you talk about retinoblastoma, this is the tumor here. They have asked you what is the most common mode of presentation. Most common mode of presentation is, of course, leukocoria. And what is the second most common? Second most common, let's talk about is strabismus or squint, right? Okay, I'm not writing, but let me quickly discuss this. Most common mode of spread, please answer through the optic nerve. And most common non-ocular malignancy, you will say osteosarcoma. Okay? And this is the ultrasound with this tumor here, and we can see some calcifications. It's important to know that this can be one of the causes of intraocular calcifications. Then we talk about the pathology. This is a true rosette with a central lumen, as you can see here. This was your exam question. This is Flexner Winter-Steiner. Ye kya hai? These are all differentiated tumor cells. So one differentiated is Flexner Winter-Steiner. If there is no central lumen, these are pseudo-rosettes. What do you call pseudo-rosettes? I hope you know. Homer right. And of course, the third one is your fluorates. So these are the different types of differentiated tumor cells of retinoblastoma. So just remember, and I want you all to revise the ICRB classification of retinoblastoma as well. Please do it yourself. Any doubts, you can DM me and directly ask me, right? On the Insta, you can do it on the Insta. Okay, then we talk about what is this slide? Yes, it's time to discuss the lesions of visual pathway. Everybody knows the visual pathway? The two retinas of nerve fiber layer forming the optic nerve. The two optic nerve, if this is your left eye and this is your right eye, always we learn like this, left ka left, right ka. Now what happens, the nasal fibers are decussating, temporal will not. This becomes an optic tract. The decussation is called chiasma. This is the tract. Then you know lateral geniculate body and how this is leading to optic radiations. and I will just modify this diagram by making, if this is through temporal lobe and parietal lobe, temporal and parietal lobe, there are two ways the optic radiations are passing through and then coming to visual cortex. Okay? Now learn in my style, it becomes easy. Think yourself. This is all right-sided lesion which they are showing. First is what? एक साइड की पूरी ऑप्टिक नर्व चली गई, naturally उस साइड blindness हो जाएगी. So this is easy. This is number 1, A. What is B? When 2 nasal fibers are gone, of course we know we will get bitemporal hemianopia when 2 nasal fibers are gone. Many of you get confused with this. I hope now it is absolutely clear. You are revising that the projection of retina is always opposite. ठीक है, तो ऐसे समझो, the coordinates of the retina and visual field coordinates will be opposite. Isn't it? So if the temporal retina is gone or the temporal fibers are gone, we always get a nasal field effect. So if the nasal fibers are gone, we will get temporal field effect. Okay, please remember this. And then of course one eye temporal and one eye nasal, what is that? We get in the optic tract is, if one eye temporal, उसमें nasal field effect हो जाएगा, one eye nasal, उसमें temporal field. This is what is homonymous hemianopia. Okay, pay attention. If this is a right-sided lesion, we always get left-sided homonymous. Can you see the shaded part is on the left side? So left-sided homonymous hemianopia, right? So is it clear to you all? So one by one, if this basic is clear, what is this? What is this? Let us think. I get the field is this one, the temporal is there, nasal is not there, है ना? And here what is happening? Nasal is present but temporal is not there. So this is what? Homonymous hemianopia on one side. Which side? Right-sided. The same thing is shown here. So it's a right-sided homonymous hemianopia in this case. In this case. Whereas in this case it is left-sided homonymous hemianopia. I hope you understood. Left-sided homonymous hemianopia in this one and right-sided homonymous hemianopia is seen in this one. Yeah? And of course, you for your level, you should first mainly answer optic tract. Then we talk about, this is what? Both temporal are gone, isn't it? So both temporal gone means we are talking about chiasmal lesion. So at Fmge level, so there are a lot of details further into the lesions of visual pathway. I'm not taking that. Let's focus on this exam first. So this is what is bitemporal hemianopia, right? Okay, then we come to the next one. I was just talking to you that how the fibers from the temporal lobe, जो temporal lobe से fibers जाते हैं, they are inferior fibers and therefore what type of field effect they will cause? So temporal lobe lesion is going to lead to this type of superior quadrantopia because few fibers are damaged. Now because this is what is called pie in sky. Just remember superior quadrantopia happens in temporal lobe lesion and vice versa, pie in floor is seen in parietal lobe lesion. Okay? Okay. We now come to the next. What do you see here? We are saying that when the torchlight is shown here, the pupil constricts, but here it does not constrict. When again the torchlight is shown here, the pupil constricts, and when it is shown here, it is not constricting. So this side, right, this is your right eye of the patient, this is the left eye of the patient. So the right eye is not constricting properly. You are swinging the torchlight from one eye to another. Yes, this is what is swinging flashlight test, and this is the case of relative apparent pupillary defect, which is also called Marcus gun pupil. Okay, you remember this? Yeah. So this is your abnormal pupillary reaction. One of it is RAPD. We come to the next slide. Yes, here what is happening when you're showing the light, this is not constricting, this is constricting. This is the right eye of the patient, this is the left eye. Now when you're showing any near stimulus, both are constricting. Can you see that? So both are constricting here. When you remove the finger, this goes back, this is still constricted. So it is tonic pupil. This is what is Holmes-Addy pupil. Holmes-Addy pupil, therefore, is one eye is what? What is the position? Mid-dilated. This is asked in the exam. In Holmes-Addy, one eye mid-dilated. And when you are showing light, either it is a sluggish or no reaction. When you show the near reflex, it will constrict, right? But if you remove, it is still taking time to come back. This is your Holmes-Addy. It is generally seen, quickly giving you some points here, it is generally seen in middle-aged females complaining of photophobia or anisocoria, that is difference of pupil size. ठीक है, कैसे पूरा चीज कंफर्म करोगे? हाउ डू यू डू दैट? क्या बोलते हैं? We are giving pilocarpine. Normally 1%, any normal person can react to pilocarpine and there will be constriction. But if in this patient 0.125% of pilocarpine से react कर रहा है, this is Holmes ADI because of denervation hypersensitivity it is happening. और क्या पढ़ा हमने? नेक्स्ट क्या है? ये क्या चीज है? आर्जेल रॉबर्टसन प्यूपिल where there is light reflex is absent, near reflex or accommodation reflex is present. ठीक है, आर्जेल रॉबर्टसन term is used for when it is due to neurosyphilis. Otherwise, what do you call it? Light near dissociation. ठीक है? Okay, we come to what is this slide. So these are all abnormal pupillary reactions. What I see in this patient is mild ptosis. I know you have guessed already what we are talking about. I can see a meiosis if you compare with the other eye. This is your meiosis, है ना? And of course, apparent enophthalmos, not a true enophthalmos. And what else you get is your anhidrosis and loss of cerebrospinal reflex. So question that has been asked is in Horner's syndrome, which is, please revise this, what is Horner's, okay, important topic. It's a lesion of sympathetic chain. आपसे पूछा गया है Horner's में best described by, you will answer ptosis and meiosis. ठीक, it is best described by ptosis and meiosis. Okay, when we come to this one, what are these? Think yourself, all these pictures. If I have to give one heading, what will be this heading? So the heading is going to be optic atrophy. All the nerve fibers are damaged, patient is blind, no pupillary reaction. Now optic atrophy, when it is happening, anything behind, the causes behind lamina cribosa till brain. It could be multiple sclerosis, neurosyphilis, it could be nutritional, it could be hereditary, it could be traumatic. Everything comes under primary optic atrophy. So when you say primary, how will, if I have to just look at the patient and say, अच्छा बताओ ये क्या कौन सी atrophy है? So primary optic atrophy, as you can see in the slide, has a clear disc margin, chalky white in color. So this is your clear disc margin and chalky white in color, right? We come to the secondary. Secondary में क्या देखते हो? Secondary का मतलब secondary to the optic nerve problem. That is either papillitis or papilledema. And therefore, what you get? You get what? You get a blurred margin in papillitis and papilledema. It's blurred. So here also, what do you get? I can draw to make it simple, a blurred disc margin, and we will learn it as dirty white in color. Blurred disc margin, dirty white in color. This is your secondary optic atrophy. Secondary optic atrophy. Correct? Then we talk about third is glaucomatous, which happens due to glaucoma. I think we have discussed this. Glaucomatous, it is CD ratio is more than 0.6 or 0.7. Nasal shifting of vessels, laminar dot sign, bionetting sign. So वो सारा कुछ आ जाएगा as glaucomatous optic atrophy. समझ आ गया? चलो, lastly कौन सी बची? Consecutive means due to retinal disease, and the main cause is retinitis pigmentosa. Important topic, okay? So this is your consecutive optic atrophy. Please revise RP, अच्छे से पढ़ना है. Please learn it in detail. So RP, of course, you know, is a triad of, I can show it here. It is a triad of pale waxy disc, attenuated arteries, and bony spicules. They ask you the triad, right? So it's a dystrophy of what? Rods and cones, and primarily it is the rods. Please learn retinitis pigmentosa in detail, right? Okay, and what do you see here? What I see here is, I can see dilatation of veins. And I can see blurred disc margin. Yes, we are talking about papilledema. Too much of edema, so much as if it feels that the disc is all elevated. And there is what? Dilatation of vein is the first sign of papilledema. This is the exam question, okay? First sign of papilledema, it is venous dilatation. Correct? Okay. And because of this, what type of optic atrophy? Of course, secondary optic atrophy. This is what we see, blurred disc margin, dirty white in color. Right? Okay, so that was all for this session. I've tried to cover as much as possible. I actually felt very, very impossible to touch everything before the exam, but I'm trying my best. I know I'm a little fast here, but that's what it is. It is what it is. If I have to cover things, I have to be a little fast. Hope you enjoyed the session. If you think there are some things which you are not knowing it properly, please go and study. Go back and study, okay? Yeah. At present, the only thing that you have to do is focus, study, focus, and never go in self-pity. Please, Understand it is your journey. Try to be better than yesterday. No complaints, only hard work. Okay. Thank you so much. Stay blessed and keep smiling.